Good morning, dear students. Today we are starting a new topic in neurophysiotherapy, neurology, epilepsy, and epilepsy related seizures. So, what is the definition? See, basically, the International League for Prevention of Epilepsy or Association of Epilepsy is against fight against the leading association which is acting against the epilepsy syndromes throughout the world. So I thought their definition would be the best definition. So conceptual definition of seizures and epilepsy, which is a 2005 report of ILAE. So according to this definition, an epileptic seizure is a transient occurrence of signs and or symptoms due to abnormal excessive or synchronous neuronal activity in the brain. Epilepsy is a disorder of the brain characterized by an enduring predisposition, that means which is existing, already existing or undergoing process in which is undergoing, which may trigger to generate. So that's what we understand by enduring predisposition to generate epileptic seizures, and by the neurobiologic, cognitive, psychological, and social consequences of this condition. So epilepsy is a disorder of the brain which is characterized, which means that the characteristics are based on pre-existing or undergoing conditions which generate epileptic seizures. And the reason or the basis behind this type of characterized seizures or this condition is based on various pathologies such as neurobiologic, means biological process of the neurons in the or the brain, the basic process biological functions of the brain, intellectual functions of the brain, that is the cognitive, what we mean by intellectual, as well as all the higher mental functions of the brain, psychological and social consequences which may be altered due to this condition. So to define an epilepsy for a particular patient, to diagnose or to define, requires that the occurrence of at least one epileptic seizure. Without understanding one epileptic seizure, the physician or the neurologist will not be able to define it. Introduction. So we can say that what is a seizure? Normally we can say that convulsions associated with febrile diseases. So febrile diseases means mainly related to high fever. Any condition which is infection leading to high temperature may be called as febrile disease. So febrile any hyperpyretic diseases due to may lead to seizures. 2 to 4% of all children before the age of 5 have this what we call as febrile seizure, but we should be able to say that it's purely febrile seizure. So other is symptomatic seizure related to any kind of other neuropathology which is as a symptom, seizures as a symptom for a basic neuro based pathology. Epilepsy is recurrent unprovoked seizures, which is recurrent unprovoked. There is nothing, no provoking needed. It is happening involuntarily. So this recurrent unprovoked seizures we will call as epilepsy. In the first year of life, almost 1 to 2 of the 1000 delivery happen to having epileptic seizures. In childhood, it's around 0.5 to 1 of 10,000 children. So in the first year of life, and is more susceptible for epileptic type of syndromes. So what is happening basically is related to the synaptic transmission. We have to understand the synaptic transmission, or what we call as neuronal transmission. So neuron to neuron communication is mediated by what we call as NTs, which are neurotransmitters. And the neurotransmitter may transmit whatever is the mode of transmission. It can be electrical, neurochemical, or hepatic. So whatever may be the type of neurotransmission happening, but resultant may be the one neuron uh, gives a signal to another neuron. The resultant neuron stimulation may be what we call as excitatory post-synaptic potentials and inhibitory post-synaptic potentials. So if it is a synapse to synapse kind of transmission, and this synapse to synapse kind of transmission may have two types of excitation or inhibition. So the postsynaptic potential may be excitatory or inhibitory. Excitatory neurotransmitters which we understand is glutamate and aspartate. Inhibitory are GABA and glycine. So GABA and glycine are the inhibitory neurotransmitters, and glutamate and aspartate are excitatory neurotransmitters. Electrical coupling of neurons. So understanding the basic understanding of the electrical coupling of neurons in areas with densely packed neurons. So areas where there are densely packed neurons means that they should be having lot of synapses and connectivity. So the one area such area which has a higher density is the hippocampus. So the neurons may be connected via gap junctions or communicate via aphatic transmission. One is the gap junction, that is a synaptic, this thing is there. What you call neuronal synaptic junctions are there. So and neurotransmitters are transmitting. Those can be electrical or chemical, electrically stimulating. But the other one kind of transmission which is not like a via gap junctions are called as aphatic coupling. Emphatic coupling is a form of communication within the nervous system and is distinct and direct communication system like electrical synapses and chemical synapses. It is distinct. It is not like it is not same as the electrical or chemical synapses. So those kind of simulations or connections are called as transmissions are due to what we call as, so they are not called as transmission, the aphatic transmission, they are more called as a aphatic coupling due to close opposition of membranes, allowing direct propagation of seizure discharge. So these kind of transmission, what will happen, a particular neuron goes into gives a seizure discharge. This discharge will transmit, not only through chemical or electrical methods, it can also through propagate through aphatic coupling. So etiology can be divided. So specific etiology identified cases only. So most of the cases, only 35% of the 30% of the cases are clearly identified. Okay, out of the identified 30%, if you take that as 100%, you have 67% of idiopathic. So that means that most of the conditions are not understand. The basis is not understood well. 20% is mostly congenital. In the congenital form itself, we are seeing traumatic, then HI, which is called as hypoxic ischemic encephalopathy, due to hypoxia, and congenital brain abnormality, that is structural anomalies. And then you can see, so this 67 and then 20, the rest is trauma, infection, vascular, and neoplastic. So causes of neonatal seizure, I already told you. If you're talking about cerebrovascular, such as the what happens in the stroke, so stroke-related seizures are seen in adults. In children, also it can happen due to any congenital cerebrovascular accident, such as in case of what we say is like cerebral palsy, as well as in infantile hemiplegia. Intraventricular hemorrhage, hypoxic ischemic injury, cerebral infarction, and genetic or the metabolic or what we call as the symptomatic seizure kind of conditions due to genetic problem or metabolic problem, in which includes chromosomal abnormalities, inherited benign familial, amino acid disorder, organic acidemia, urea cycle defect, non-ketotic hyperglycemia, mitochondrial disorder, neurocutaneous disorder, and others. In acute metabolic problems, so this can happen only due to sudden fluctuations in the metabolic levels, that is say what we call as electrolyte levels, can lead to acute metabolic related neonatal seizures. So neonatal seizures due to acute metabolic problems are due to reduced sugar, reduced calcium, reduced or increased potassium. Infections such as bacterial meningitis, torch related infections, viral encephalitis, cerebral anomalies such as hydrocephalus, which we already discussed in the earlier classes, migration abnormalities. These are all structural anomalies. Agenesis of means underdevelopment of corpus callosum. The corpus callosum does not mature. Holoprosencephaly, lysencephaly, all related to the abnormalities and the structure and the shape of the brain and other conditions. So I just added here seizures due to stroke because in the adult, some severe cases, very few percentage we can see seizures. In acute stage in the ICU level, it is more seen, but later on also some patients may show seizures. So seizures due to stroke, seizures occur in a small percentage of patients with stroke and are slightly more common in occlusive carotid artery disease. 17% are more comparatively and occurs in the occlusive. That is what is occlusion? That is not hemorrhagic. This is due to leading to ischemia, maybe due to thrombus or any kind of embolic condition. Then and in this itself, we can see that more conditions the MCA. So MCA middle cerebral artery conditions are 11%, 17% you're seeing carotid disease. Seizures are common right after stroke. Right after the stroke happens, that is in the early acute, very very acute stage, the phase. 15% of the cases with cerebral hemorrhage, in cases with cerebral hemorrhage, and late onset seizures can also occur several months after stroke, and that more normally usually we see in cases related to MCA disease. They tend to be of partial motor type. They are not related to any specific kind of unusual seizures which you see in the neonate. They are related mostly of a partial motor type related to a particular area of the body. Seizures are potentially life-threatening if not controlled, especially a patient who has undergone stroke. If along with that seizure also occurs, then it is potentially life-threatening, leading to a fatal condition. So in a partial, only a portion of the brain will be affected. So what will happen? Sometimes the person is normally conscious and shows some kinds of jerky movement in one area, finished. No, then gone. In complex, it will be severe as a normal seizure. Patient loses consciousness, then starts, so that goes to unconscious stage, and that type of seizure may lead to many types. We will discuss that later. In the if it's not in the partial, then it's a generalized. So both hemispheres are involved. So in the stroke, we talked about partial, and partial in some cases simple and some cases complex. So complex may lead to fatal conditions. In generalized, which is not related to stroke, here the seizure type is going to be very severe. All the body, the whole body is going to be involved. So epilepsy classification is very very tough actually, and most of the time we as a physiotherapist we don't understand, but we try to understand what is the basis behind it and try to go along with the condition and to continue our therapy along with the understanding the condition. So clinical presentation is quite variable, means it always can change. It is not going to be 100% definite. So we try to come to a definition or understanding by using the age of the onset, seizure type, interictal conditions, EEGs, outcomes. So which all of this can be taken into consideration to come to a classification, into which classification should we put this epilepsy syndrome. So to evaluate after doing that, the understanding the clinical presentation, we have to evaluate the epileptic syndrome. Possible etiology, some genetic possibilities can be understood. The seizure, or if there is any genetic structural anomaly, any lesions or any disease, so then it could be understood. The seizure type and syndrome type determine the specific appropriate treatment and further evaluation. So all this classification is very, very important to understand the seizure type and the syndrome type, and then only we can give appropriate, correct, optimal treatment and go for further evaluation. So